Namaskar. Hello and welcome to this episode of Aarogyata Aphorisms. We have with us Dr. Surbhi Vash, the president of Aarogyam Institute of Integrated Medical Sciences. And today we are with you to discuss all about the dynamics of telemedicine as a discipline. COVID-19 pandemic has hold us all, locked us all in our own homes, despite the gradual opening up of uh, the outside markets. The most haunted space remains the hospital. Even earlier, going to a doctor was always a thing which we always used to delay as much as possible. कर लेंगे हो जाएगा बीमारी मैं बीमार हो नहीं सकता there's a natural denial with all of us. But considering the pandemic, considering the level of infections, it is also advised that until or unless it is really major urgency, we can try to do a kind of teleconsultation, not visit, especially the medical facility, because despite all the precautions out there, and due to the heavy load of the COVID patients, it's really advisable that, and especially if you have some comorbidity, diabetes, blood pressure, if your immune system is already a bit lower. So, telemedicine as a discipline has been existing for a long time, since the time computer science came, information technology came. So, it was thought about that the entire process of consultation, the way a doctor does, it can be done in a digital mode. But then the bandwidths were low, the penetration of computational devices was not that much. And most importantly, we patients, we the commoner citizens, we did not have the incentive, because especially in India, we always need a caring touch, a kind of a personal touch out there. So this episode of Aarogyata Aphorisms is aimed at unraveling the dynamics, the whole process, and learning from the horse's mouth. People who have been trained looking at hundreds of patients in a single OPD at the All India Institute of Medical Sciences. So, welcome, Dr. Sulbhi, to this episode of Aarogyata Aphorisms. Uh, uh, with these opening remarks, what exactly is telemedicine?
Thank you for bringing me to this show, and this is a great opportunity to talk about the relevance and importance of telemedicine as a practice. And basically, telemedicine, before the COVID pandemic came, this was quite a term which was, a practice which was being practiced but not legally sanctioned by the Telemedicine Society of India, and so on and so forth. But then now with the COVID onslaught, telemedicine has become the buzzword, and hospitals across are trying to adapt themselves and take on to the telemedicine practice. So what is telemedicine? Like, if we go to the etymology of the word, it's very simple to dissect the word telemedicine. So any consultation which happens, with the help of a tele device, it may be a phone, it may be a computer, it may be a laptop, and where the patient is not present in physical form, and it's a teleconsultation, can be categorized under telemedicine. And formally, there are various channels, like there are various companies who have launched the app, the platform, the software, the tools. But then a WhatsApp and an audio video consultation is something which is also telemedicine.
Dr. Subi, well, the legal aspect of it is probably the regulatory aspect. We will not delve deeper into it, but thankfully, doctors, the registered medical practitioners, they can consult the patients under the telemedicine guidelines. It is completely legal now, but yes, there is a big asterisk mark that telemedicine is not for emergency care.
Yes.
If you are really finding something which is acute, rush to the hospitals despite whatever, because the recovery rate of COVID is still 90% plus. So don't rely on telemedicine for emergency pressing problems. For that, institutional care is the only thing which is done. But what telemedicine is actually bringing about is a cultural change, is a shift that you can approach a doctor even before you have felt ill.
Yes.
So,
So very nicely you've summarized and articulated this point. Basically, that there are many health problems which are ignored, which are lying under the carpet, which are, if diagnosed and addressed timely, they can prevent the bigger monster form of the disease coming in. So where the preventive aspect is there, even in the therapeutic consultations, where we have the aspect of that diagnosing in the right time, though what the input is there to the doctor in the form of physical examination or symptoms which are from observation, that may be slightly plus minus, like it might not be that much accurate. But then even in this medical science, and the healthcare professionals have, kind of upgraded themselves in the form of that, even if there's a village, and if you have a paramedic or a skilled professional who knows how to measure the blood pressure through, and these days we have all these automated
Dr. Speedy, I would
machines.
say, telemedicine remains a very technical discipline as well. In fact, medical science, because doctors deal with the best machine in the world, even the best of the technocrats and scientists have not produced a machine even closer to the human body. So this is a fact which is even accepted by the best of the scientists and engineers and technologists across the globe. I would say that let's dissect for our viewers a very simple process from a layman's perspective, a first principles perspective, कि जब एक patient एक doctor के पास जाता है, तो doctor, because there is a process of consulting, there is a process of interacting. So would you please like to tell the dynamics of consultation, and of that dynamics of consultation, what all is possible in the distant consultation mode, and what are the areas where there is a help required, or intervention of a physical intervention is required. So that will probably help people to understand that what is the nuts and bolts of telemedicine, because these days lot many terms come and they impregnate our ears and mind and we don't make sense of it, but we have to accept, क्योंकि हमें दिखाना है कि भाई हमें समझ में आता है, हम पढ़े लिखे हैं. पर कई बार many a times, at least for most of us, many of us, समझ में नहीं आता पर मानना पड़ता है. तो
so a teleconsultation, or typically a medical consultation, comprises of, the first step is history taking, where the patient comes to the doctor either on a teleconsult or a physical consult. He gives you that I am having the presenting complaints, what we say. So if there is a symptom of sick cough, or additionally what are the other complaints, fever, or maybe there is a headache, so then we arrive at a differential diagnosis or a provisional diagnosis.
So patient just talks about himself. That
Yes.
That in your technical language is called history taking.
Yes.
Do you also screen the patient in terms of some vitals when he or she enters? Is it required, or just
Yes.
story telling is good enough?
So in an ideal setup where you have a nurse, you have an ideal setup in physical consultation, a vital measurement is always recommended, where you may be measuring the weight, especially in pediatric age group. Weight is very important, because the dosage of the medicine is decided according to the child's weight. So weight, height, of course, for the BMI, blood pressure, and maybe if the patient is feeling feverish, then we measure the temperature as well. So these vitals, when they are recorded and presented to the physician or to the clinician right before the consultation begins, so it adds to the
so
speed and efficacy.
Can it be made a part of the registration process of teleconsultation when a patient is registering? Because then he or she gets enough time, because most of the teleconsult people are the ones who are educated ones.
Yes, it's a great thought. I think
so they can register their entire complaints.
Yeah.
And then, yeah.
So the presenting complaints are very important, in the sense that because they give an insight, a quick diagnostic glimpse into what system the patient is affected from, the disease is coming from which arena of the human body, as we say, the various systems. Also, the presenting complaints will also give a hint on the line of treatment, the prognosis. Now, from the presenting complaint, we have to go deeper. And here comes the art of history taking, where we need to elicit more important facts, maybe in the immediate recent 15 days or 3 months. Then there's a social history, there's a family history.
So the doctor actually interviews the patient.
Yes.
So this is in a layman terms, a doctor actually interviews the patients and at times interrogates as well.
Yes,
Is it
yes.
right?
It's very well known that
Because
doctors
many
ऐसे
times
कुछ
we
छुपता
keep
ही
on
नहीं है.
hiding some of our factors
Yeah.
for want of social things. You have to ask the patients any vices, any.
Yes, these need to be told very honestly and
Mhm.
candidly, and it's the doctor's responsibility and art to elicit all these facts also, because this will also determine
So,
the
doc,
prognosis.
does it somewhere comes to you that the whole process of telemedicine, I am having a discomfort, which is not emergency one.
Yes.
It can wait, but I need to redress that. So, if I fill up a elongated registration form which asks me everything in an impersonal mode, because see, in a personal interaction, obviously it's a human thing. We all have a guilty conscience. We all know what is right and what is wrong, and somewhere or the other in our cultural ethos, falling ill is not considered good. कि भाई तुमने कुछ गलत किया है इसलिए तुम बीमार पड़े हो, because and somewhere or the other in our own Indic philosophy, Aarogyata, the state of free from disease,
Yes.
is something very central. And
Yes.
from a civilizational perspective, falling ill is not considered that good. So if a registration comes in a dispassionate format, in an impersonal format, the doctor can read it across, and then only if he or she has some
particular specific questions,
and that way the patient has got enough time and opportunity.
Yes.
Because otherwise, in the rush of a physical clinic space in an OPD, the rush is so much.
Yes, yes.
That
the elaborate history taking is almost always not possible. And in fact, this is the usual case when we have, you say in the PC, in the PHCs, or in the community healthcare centers, the CHCs, we have the 1,000 patients in one OPD. Now, how this is humanly not possible, but then this is the state of our health condition in the country.
So ideally, what proportion you put in the diagnosis of it, the history taking, what is the importance of history taking?
History taking is extremely important. I would say at least 50 to 60% of the entire line of treatment diagnosis.
So basically, it is mapping with those of us who are from the software industry, that the software lifecycle model, the user specification generation consumes the maximum amount of time, more than the coding and the testing part of it. So I think the same ratio in some way or the other applies to the field of medicine as well. Okay, this is really interesting. So doctor, with all kinds of these fancy tools, platforms, things coming in, projecting themselves as to be the telemedicine solutions, what is the core thing which a medico actually needs for arriving at a diagnosis?
So diagnosis is an art and a science both. So where we say a diagnosis may be first a differential diagnosis, then we achieve a reach to a provisional diagnosis, and then on the basis of certain gold standard tests or certain diagnostic modalities, the confirmed diagnosis is reached. Very often the diagnosis is very clear. At the outset, you can say that this is most probably this is the diagnosis. So now what
I will stop you here. You mentioned a very important term, and I would like the attention of our viewers to this very important term, differential diagnosis. You said that a doctor, the clear cut diagnosis कि यही बीमारी है, this is not very clear.
Yes.
Because you also said that diagnosis is an art as well as a science. So do you mean to say that the human body, the lakhs and crores of us who have been studied for ages altogether in modern medicine, so still after that you don't have a very conclusive proof or very clear cut stuff कि भैया आपने नब्ज पकड़ी और यही रोग होगा आपको?
There is a reason to this, because medical science is something, it is dealing with life and death, and a diagnosis जैसे कहते हैं नुक्ते के फेर से खुदा जुदा हो गया. So if you are missing the diagnosis even by very close, if you're missing the diagnosis, the line of treatment changes, the outcome changes. So we have to be very wary. And I would say that modern medical science is now dependent on a lot of tests, which I say it's both a it's both a strength and also a shortcoming, in the sense that a lot of diagnostics or diagnosis comes from history taking. A good history which is elaborate, which is complete, which has the facts, has the hidden secret to it. Then comes some vitals in the physical examination. Some vitals may help you clinch or corroborate that diagnosis. And in the end, a test or a parameter which is deciphered from a radiology or an ultrasound or something of a diagnostic test will corroborate the diagnosis. I'm not denying the role of diagnostics, pathology, ultrasound, radiology, CT scans, MRI scans. They're all important, but then a preliminary diagnosis, a provisional and differential diagnosis can always be inferred from the history taking. And differential diagnosis, what we mean is that accuracy, accurate diagnosis, as we say, is very important. And accurate diagnosis comes from, the humility that this is the diagnosis most probably, but to eliminate the other possibilities. This is what we say in differential diagnosis. At AIMS, in our training, we are really emphasized upon on the differential diagnosis aspect, especially the red flag signs, the diagnosis which are like the cancers, maybe the terminal illnesses. We have to be doubly sure that we are not, missing on those diagnoses. So not to scare the patient at the outset, because there's always a possibility this could be there, this could not be there. So that's where the term
so
differential
is this the
diagnosis.
very reason that you doctors call we patients as patients? Because we have to be really patient as to
Yes.
what is really happening to us, huh?
Yes.
Because we are not patient at many a times. We want quick fixes, fast food.
Yeah.
So
Along with the quick fixes, the Google phenomenon is in also a new observation in the recent generation, where they will read up on the Google and they say, doctor, are you sure he needs the surgery? Because Google says these are the parameters on the basis of which the surgery should be decided. The surgeon is just looking into your eyes, and so it's medical practice is something needless to say. I mean, these 2 points, that you need to be patient and you need to trust the doctor. Once you have imposed your trust in the physician, you have to continue.
You talked about the Google doctor. It's perfect. It's a perfectly fair criticism. But doctor, in today's time, when the trust factor between the professionals per se, the professional ethics are somewhere compromised because of the bottom line and the top line.
That's a point.
There are gaps in the statutory space where there is no accountability involved as to how much diagnostics you have actually prescribed for.
Absolutely.
So the patients are really, they're really terrified in going to a doctor. In fact, we read in our early classes kind of an adage, a very funny one, कि वैद्यराज नमस्तुभ्याम यमराज सहोदरः यमराज हरन्ति प्राणः त्वं प्राणान् धनानि च. Oh my dear doctor, you are the sibling of Yamaraj, the god of death. Because Yamaraj only takes away my life.
Yes.
You take away life, but also my money. So how this increasing trust deficit, it can be bridged upon?
See, I would say one thing, that to take cognizance of what you've just said is there in the population today. We have medical malpractices. We have overprescription of tests. Sometimes, many a times, in fact, we have overprescription of medications, and diagnosis is often not taken to that depth, of differential and provisional diagnosis. And many a times we are, so the to say it in to be fair to the doctor and to the patient both. You see, if you want to be sure, the patient wants to be doubly sure that, look, am I getting a good fair consultation? It's good to read up that there's no harm in the patient being aware, but then this has to come from the doctor as well, and the doctor has to educate. That's where the health awareness and sharing knowledge, where we say that a jagruk banana, awareness about the various health issues and how it can be prevented, at the initial stages, at the primordial stages, as we say. So this kind of we doctors in the medical community need to take this responsibility and onus in a major way, that we have to not keep all the knowledge to ourselves. At least the preventive aspect of it, what can go and percolate into the society, to the population, so that they can also, their trust increases in the medical community, in the fraternity, in the doctor per se, and they are also able to handle the initial stages and report to the doctor as in when the disease is coming, and the borderline where it can be prevented. That's where uh, the knowledge aspect of it comes really into play. And with knowledge we have a this to be healthy is an attitude, like we say I want to be healthy, I have to be healthy is an attitude, and this attitude comes from awareness.
So, Doctor, one interesting part. So, since this episode is focused on telemedicine, and
Yes.
for our viewers, I would like to say that the purpose behind these Aarogyata aphorisms is to create kind of an authentic content with a kind of a generalized concerns which all of us face while dealing with the medical fraternity, so that we can be further educated and sensitized and how to actually approach care. Because yes, as we are moving forward, even our Google bots, they read up our browsing history and they present us marketing hooplas according to that. They change their search results so that they create a kind of a filter bubble around us. So all that is happening, and obviously regulation is slow to catch up with the speed of technology, with the speed with which the control of the human mind is being taken. But it's still, I would say that the medical fraternity, the kind of ethics which are still there in the whole medical space, because the Charak's oath, the Hippocrates oaths, the kind of ethics which are still there in medicos, and obviously how to search a right healer, that is very, very important. Doctor, one of the challenges, one of the concerns, which is not probably the subject matter of this talk, uh, is that we have heard lawyers charging hourly basis of consultation, right? Just a decently practiced enough lawyer would say, oh, I charge say 3K, 5K, 10K, and then it goes. There is no upper limit for that. And lawyers are known by their, oh, I charge this much for an appearance, and I charge this much for a conference call. Doctors are not known to charge on this aspect. So as you say, the financial incentive, it somewhere gets structurally deflected in towards the pathology platforms, towards the diagnostic internally. I'm just saying, because see, in today's time it's always the zenith, because at the end of the day it's all benchmarked only and only from the bottom line considerations in today's modern progressive world. So how do you think, does it really have an impact with the medical fraternity, you coming from there? Is there a kind of a dejection, frustration, even after working so very hard for these many years, and even after being so truthful to my profession? Uh, so that, and is it somewhere the reason for this lack of delivery?
See, healthcare expenditure, healthcare budgets from the public government side, on the private, you know, from a person seeing the per capita income, all that. These statistics, we all know that, healthcare is not plush, and doctors are not, um, you know, I mean, the commensurate remuneration is not there at many instances. But I would say that a doctor, a medical healer, a doctor, for him the greatest satisfaction, for him or her the greatest satisfaction or the reward is the patient getting fine, the patient recovering, the smile on his face, and how he greets the doctor, thanks the doctor, even if he's, whether he's able to pay or not pay, that is second issue. But the reward, it gets the blood in the veins, it just gets you going. For a doctor, I think the reward, the biggest reward, is the patient smile, him getting healed. But of course, in the long run, the monetary aspects, these are a part of the transaction. But then medical profession, that's why we say it's the noblest profession of all. you are the goal, as Charak Sod says, that not for any wealth, not for any fame, not for any personal accomplishment. I heal the patient for the patient's welfare, for the patient to heal. This is why doctors are said they're next to God. So a true doctor who is compassionate, who is empathetic, who is skilled, who is knowledgeable, and who is ethical. I think these are the five attributes which the hallmarks of a true doctor. For him, the greatest reward is the smile of the patient.
Having said that, but still, I personally feel, coming from a policy discourse, that there is a need to structurally incentivize the doctors. Why should doctors not be paid well for their consultations? Because if the doctors are remunerated well for their time, they would really pass on their knowledge, because nothing comes for free. I remember my childhood ulta flop show by Jaspal Bhatti sahab कि पड़ोस में डॉक्टर साहब थे और उनको चाय पे बुला लिया, और चाय पे बुलाकर उनके साथ में the thought was to extract all the knowledge from there. So somewhere or the other in our Indian society, knowledge professionals have somewhere not been rewarded by our indigenous society at large, because traditionally knowledge professionals were Brahmins, and we had a different economic structure at that point in time.
Yes, so, and I would also say that when you pay a doctor, the spirit, the culture has to be the doctor should not have to ask to demand the fee.
Yes,
it should be an attribute as a respect, as a mark of gratitude. A patient should just pay the fee. That's the ideal culture, I think, or the kind of atmosphere which incentivizes the medical chain of the entire process.
So, doctor, I think somewhere or the other, the intervention of technology in the space of medicine, especially at the primary level in the sense at the OPD level, when you have a presenting problem or discomfort, and when you reach a GP first, the doctor on record. So at that point in time, your history, your entire medical portfolio gets created. You have ample amount of time doing it back at the back end, putting things across, and doctor also gets a kind of a screening or a quick reading a doctor can go, because he or she gets a snapshot. So telemedicine is somewhere protocolizing the entire care. It's standardizing it, in fact.
Absolutely.
Do you feel that?
Absolutely. I think this is the great power of technology, where the telemedicine is, really empowering the protocolized kind of medicine. And somewhere we say and we feel that in India, we need to still come to protocolized medicine in a major fashion, in a major way, because a lot of medical malpractices, where it comes from, in whichever quarters it is there, comes from if we are having a systematic, mechanized, although the art of medicine also has its own role to play, but protocolized medicine, John Hopkins, say the US and the NHS system of healing, they have these very nice guidelines. So these guidelines are indeed helpful. In fact, I would say that 80% of the problems in the medical parlance are of primary healthcare conditions. And primary healthcare conditions can be treated at that level with a bit of an art of a differential diagnosis.
They got ignored, you mean to say?
Yes.
Okay.
Because the role of the GP has been very much ignored, and we don't have a department of family medicine in our country now, an MD in family medicine, so on and so forth. Still, it's coming up in DNB. We are having some courses, and some CMC Vellore is offering, and so on and so forth. But then this speciality, this discipline of a GP, of a family medicine, of a family doctor, this needs to be encouraged.
I think again there's a huge policy gap because quite a social cultural gap, that each of our MBBS student goes in the rush of doing an MD, the amount of time he or she has invested in doing an MBBS, the same amount of time goes in mugging up for the MD entrance exam. And there is no incentive in the society at large where you really start practicing, because doctors are considered to be the best and the fiercest entrepreneurs. All they need is a stethoscope, a blood pressure instrument, and just a table and chair under a banyan tree. So, so
True.
this is what is the minimum investment profession, profession of I would say metal and commitment, as Dr. Surbi said, that giving care, the passion to give care is something which medical fraternity is really charged up with. I think a lot of course correction would happen with these discourses coming in, with society facing a lot of challenges. And I think as the central point is telemedicine in today's Aarogyata aphorism, and as Dr. Surbi is saying that it is a good way of trisecting the whole process of consultation. The patient goes, puts up his or her history in a impersonal fashion. The doctor has the leisure and time to read it beforehand, like the judges in the courts. They do come prepared for their judgments. They have all the written statements, everything out there, and then a short kind of a interaction with the doctor where he or she interviews the patient, and at times interrogation if at all required, and then he or she sends them to further diagnostics. And Dr. Sulbi mentioned a very, very important thing, which is great to know, that if a good GP, if he or she spends a really good amount of time, and more than the time, the attention on the presenting problems, the amount of diagnostics required considerably goes down. We don't have a primary data regarding that, but yes, this is a kind of a heuristic we can always draw. Dr. Subi, one last question.
Mhm.
There is a concept of doctor on record, which you have been advocating, coming from the legal profession, where we always have in the high courts and supreme courts an advocate on record. There might be a very senior counsel advocating for you, arguing for you, but there is always a doctor on record who maintains your entire writ petitions, your entire procedural aspects. So you are advocating a term called doctor on record. So
Yes.
would you please just try to throw a bit of a light on this?
So very much, it is very often found that a patient has, initially gone to a maybe a doctor who is a general physician, and then needs to be referred to the further specialties. This is one case scenario. Now there may be two three specialties which the patient needs to consult. Very often it is found that the patient is going helter skelter, this department to this department. Obviously the system of doctor on record says that the GP or the doctor on record, the first point of contact is the doctor of record on record, and he or she would coordinate for you the entire healthcare treatment process. So if it requires a referral specialist consultation, the doctor on record will coordinate with the specialist. So this is like a referral, where the expert opinion would be gathered and the case would be corroborated. The consolidated opinion would be given and administered by the doctor on record. So till the end, it's like hand holding the patient from, if even it requires an IPD admission, the doctor on record is in the know-how of what is happening in the hospital. He's coordinating and talking, interacting with the medical superintendent there. This is the kind of philosophy of treatment which leads to trust. It leads to seamless healthcare delivery. And the most important aspect of this is counseling, where the patient is in the know-how what is actually happening to him. Because specialists, or as we go to multiple doctors, there needs to be one authority who is corroborating and who is holistically validating the entire case for the patient.
Mm-hmm.
The patient feels very much at comfort.
Mm-hmm.
And this is what, like we used to have earlier in older times, the family doctor. So the doctor on record is also a kind of person whom you can trust, whom you can tell your worries and concerns, your questions, your
Mm-hmm.
queries. This is very
So
important.
the advent of technology somewhere helps this fast track
Absolutely.
multiple referrals,
Absolutely.
converging them together,
Correct.
and giving the best care to the patients per se.
True, true. Because the entire system of electronic medical records, and how it can be, the dossier can be presented to the specialist by the doctor on record. The specialist can have a look at it and then
True,
give
true.
through the event of technology, to the use of various
So the
modes.
throughput of the specialist also increases like many
Absolutely.
folds, because if a doctor on record intervenes, he or she can brief the senior counsel, the
Yes.
senior doctor.
Yes.
uh,
So the time taken for the second reading of the case, don't need to read it from scratch. The interpretation of the doctor on record can be taken as first line of treatment.
And
Of
as you
disease.
said that there is a whole lot of differential diagnosis. So there might be a problem accruing from one of the human systems. So if a GP refers to three super specialists, so
Triangulation and
a
validation.
triangulation happens.
Yes, yes, that's a very important.
I think it has been a very interesting, a very insightful aphorism, a very insightful episode. We will stop now. ज्ञान की ये जो सतत धारा है ये चलती रहेगी. हरि अनंत हरि कथा अनंता. So medical sciences, they say that it is practice. You practice till your last breath, as it is in the legal profession. So it's medical practice. The more you practice, the more experience you gather. So a very philosophical, a very judicious mix of technological repetitiveness, because technology takes care of the orderliness, handling the repetitiveness, and it adds up to the whole knowledge curve. So this was an episode focused upon telemedicine, that it has a phenomenal amount of impact. You need not now worry to travel 2 hours in a dirty weather, or in a traffic jam. So you can, from the comfort of your house, dial a doctor. Yes, a trusted one, a credible one, a doctor who really believes in caring for you. So and then the referral part of it. If the GP, if the doctor concerned cannot diagnose it at his or her end, because at the end of the day it's a differential diagnosis, it's a very complicated stuff. So a lot of inputs, a lot of gray matter can come into the place, and you can get your treatment, your medication, your everything in a very rightful fashion. So thanks a lot for watching us, hearing us. We will be back with such interesting episodes frequently. Stay tuned. Goodbye.